Today we're going to talk about fetal circulation, and the reason why we talk about fetal circulation initially is I believe if we understand fetal circulation, we'll be able to understand congenital heart disease. I think starting with fetal circulation and understanding the cardiac development is the best way to understand congenital heart disease and to understand the single ventricular physiology and how these defects occur. So, the initial thing we need to understand is a concept. What is the purpose of the fetal circulation? And realizing this idea is that the purpose of the fetal circulation is two things: to provide as much as oxygenated blood to the brain and heart, and these are the functioning and developing organs of the infant. It's very important to understand it this way because it will understand why these shunts exist the way they are, why they're anatomically placed the way they are, and how defects can originate if these are disrupted. And the second concept we need to understand is blood flow is the main factor that determines chamber, valve, and blood vessel development. Any disruption of the blood flow will cause malalignment. For example, hypoplastic left heart syndrome can occur secondary to mitral stenosis or aortic stenosis. So the ventricle will not develop per se, even though there's cellular autonomic defects that can cause that in the left ventricle. That does not deny the fact that the disruption of flow is one of the main factors for causing hypoplastic left heart syndrome. Third thing to understand is how the pressure circulations work. So placenta is a low pressure circulation. It's a low pressure circulation because, one, the large surface area that it has, and it's providing to a higher pressure circulation. Again, it's the pulmonary circulation in the fetus, but the fetus surface area overall versus the placenta. Second, placenta acts as if it's a lung, but it's a really bad lung. It should be working for gas and metabolites exchange, and it's basically acting as if it's a lung or a kidney, but it's not really as good as it should be. We know that lungs develop later on, and there's stages for the lung development, and it's not functioning in the prenatal life. And kidneys really become fully functional at 6 months of age or so. So this means that the initial start of oxygenation in this fetus will be around, see, here's a 69. I want to tell you that you're going to start with a PaO2 in the umbilical vein of 30 to 35 millimeter mercury. And understand this, as it goes into, as an umbilical vein goes into the ductus venosus, we realize two things. 50% will go into the anterior hepatic circulations, and 50% will go into the IVC. And at this point, the PaO2 is 26 to 28 millimeter mercury. And that means that the oxygen saturation is about 70-ish%, 75 maybe. Once it goes into the once it goes into the right atria from the IVC, there is something called an Eustachian valve. Eustachian valve exists right here, and it's a very good strategically placed second shunt. The first shunt is ductus venosus to save 50% of the blood from going into the liver and to salvage as much as possible oxygen in the blood. The second shunt is through the Eustachian valve to go through the foramen ovale and shunt as much as oxygen in the blood into the left atria. And once that happens, that oxygenated blood that goes into the left atria will drop into the left ventricle, which means that the oxygenated blood at the left ventricle is about 65% unmixed with whatever is coming from the SVC, which means that during diastole and coronary artery filling, the heart will get as much as oxygen in the blood will go. Second thing, the left ventricle will push through the aorta, and we'll recognize as it goes through the aorta, it's about 65% oxygen saturation, and will develop oxygenated blood to the head and neck vessels. And then the ductus venosus will occur after the arch. And the reason why I'm saying this is because the left ventricle is mainly supplying what? It's mainly supplying the heart, the brain, the upper extremities, and about 10% of the body. So that's the left ventricle. That means that the right ventricle will be supplying about 5% towards the lungs and about 95% towards the body. So the lungs is a high pressure circulation. We say, hey, it's a high pressure circulation, so the shunts occur to divert away from the high pressure circulation. I like to think of it as the other way around. It is a high pressure circulation to help the shunts go where they really want, the purpose of them, which is the heart and the brain. The lung is made of a high oxygen affinity tissues. So if you give them oxygenated blood and it goes into the lung tissue, it will retain oxygen and you'll have more of desaturated oxygen on the outside. And that's why when you look at things, the lung high pressure circulation is actually occurred to make the blood shunt so it can avoid its high oxygen affinity itself and give more oxygenated blood towards the brain and towards the heart. And that means that 95% will go through the pulmonary artery into the PDA after the head and neck vessels and go towards the rest of the body. Okay. So now that we say this, we need to understand something. Now, about 450 mLs per kg per minute is the cardiac output of the fetus. And from that, 65% goes back to the placenta. So there's 450 mLs per kg per minute as a cardiac output, and from that 65% goes back to the placenta, 35% goes back to the fetal organs. So in studies that are made on humans compared to sheep, you see that humans have a right ventricular size that is 1.3 to 1.5 of the left ventricle in the prenatal life. And this is because the right ventricle supplies a higher output. The right ventricle has a higher volume that it has to eject. The right ventricle is pushing against a high pulmonary blood pressure and a high systemic blood pressure through the PDA or directly to the pulmonary artery. So, physiologically, when they're born, you'll see that the right ventricular function, the right ventricular size will be larger. And when you do an EKG for a neonate, you'll find right ventricular deviation, right axis deviation, or right ventricular hypertrophy. Not right axis deviation, it's right ventricular hypertrophy you'll see in the EKG. And that's normal, and that's physiologic. And in time, as you adjust for the postnatal circulation, you see that the right ventricular muscle mass will be bigger than the right ventricular muscle mass. So, once the transition occurs, you'll see that the placenta constrains the right ventricle. You'll see that the pulmonary vasculature bed opens up, and there's decreased afterload. So the right ventricle will have a decreased afterload, and there will be an increased preload on the left ventricle. I hope that makes sense. Right? So once the pulmonary vasculature opens, that means the right ventricle is no longer pushing against that high pulmonary vascular resistance. And that means that the left ventricle will have an increased preload coming from the pulmonary vein. And then you'll see that there's atrial and arterial communication becomes closed. And you'll see that changing in the cardiovascular physiologies, and it becomes towards an in-series circulation, as they say it. So basically think of it as the fetal circulations as this. The heart is a machine that tries to pump towards the brain. But it's brain, and it really is regulated by neurohormones. And these neurohormones are really set up by the brain and kidneys for projections. And they tell you, hey, I do need this adjustment here. I think we'll need more there. And you will see when we talk about shock, how whether the cardiac output per se changes or the component of the arterial oxygen saturation changes, but it's basically signals from the brain, from the kidneys, from the neurohormones, from the endocrine system to adjust the circulations. And if all fails, you'll develop, for example, in neonatal life, either hydrops fetalis, you'll develop left hypoplastic heart syndrome, so on and so forth. So as long as we recognize that the purpose of the fetal circulations is to provide oxygenated blood towards the heart and the heart and the brain, the shunts makes more sense as they develop. We'll understand why the right ventricle has more strain on it than the left ventricle in the prenatal circulations, and how does the transition happens. And this is why, if you ever attended a delivery, you'll notice this, that when a baby is born, their oxygen saturation is about 60% at 1 minute of life. And they reach the 70, 80, 90 mark as they go. And you seeing the 1, 3, 5, and 10 minute marks, an increase in blood oxygenation, is what you're seeing as those shunts close and the different transition from the prenatal circulations to the postnatal circulations occur. I hope that makes sense. Thank you.